Hello, I am going to take you through very briefly a guide to oxygen therapy. What I'm going to talk about is on the internet. You'll be able to access some slides and the full guidelines behind this, but by and large what I'm going to talk about today is based on the BTS guidelines for oxygen therapy for adults in emergency and healthcare settings. So we know that oxygen therapy should be considered and prescribed as a drug, and therefore that prescription should be incorporated into the drug chart. It should have a clear indication for prescription. When it is prescribed, there should be careful consideration of the perceived benefits and the side effects. Because we know that the inappropriate dose, either too high or too low, or a failure to monitor the oxygen therapy, can have serious consequences. Oxygen therapy is a treatment for hypoxemia, which is low oxygen in the blood, and not just purely a treatment for breathlessness. If breathlessness is caused by hypoxemia or low oxygen in the blood, oxygen therapy will help, but it will not help breathlessness with normal oxygen saturations. So in essence, in an emergency setting, oxygen therapy should be prescribed according to a target oxygen saturation range. It should be monitored by oxygen saturations and maintained in that saturation range by appropriately titrating and choosing an appropriate device. When you're prescribing the target oxygen saturation range, this should be clearly documented on the drug chart. In a healthy adult population, you're aiming for a range of 94 to 98%. And in patients who you may be suspicious of them retaining carbon dioxide or becoming hypercapnic, you will have an oxygen target SATs range of 88 to 92%. And those are people we know as with moderate or severe COPD or any other chronic lung disease, chest wall deformities such as kyphoscoliosis, obesity or neuromuscular disease. You aim for 88 to 92. You take an ABG, you await the ABG, and you may know this patient population either by them wearing their yellow alert band or having an oxygen alert card. There may be other target ranges you come across, and they will have been individually prescribed by the doctor. For example, it is potentially the best achievable for that patient, greater than 92% or something like that. Many patients will require high-dose oxygen therapy to help normalise their oxygen saturations during their admission. Examples of that are people with severe pneumonia, heart failure, pulmonary embolisms, sepsis, lung collapse, pulmonary fibrosis, or as we know at the minute, COVID-19, the novel coronavirus. During a critical illness, and we're thinking here of the patients who have had a cardiac arrest, respiratory arrest, peri-arrest, sepsis, a critical illness event, you're going to follow obviously resuscitation guidelines, and that is above what I'm going to talk about. But if that patient it has a spontaneous circulation, you're going to aim for your rebreather mask. And this is obviously it here. So when you're going to use this, you need to cover the outlet when it's obviously connected to the oxygen flow rate on the wall. Turn it up to at least 10 litres per minute, 10 to 15 is fine. Cover here, let the bag inflate, get the full reservoir of pure oxygen and pop it on the patient. The bag should stay fully inflated. It shouldn't be moving in and out with the patient's respirations. Once the patient becomes more stable, they have a spontaneous circulation, you're going to aim for that target SATs of 94 to 98 or 88 to 92 if that patient is a known carbon dioxide retainer, and work from there. So we have talked about the prescription of the oxygen target SATs range, and then we want to monitor that, and that's obviously by using the finger probe for oxygen SATs. If you can, do document their saturations before you commence oxygen therapy. And when you're starting it, for healthy adults, 94 to 98% target range, you're going to start with a simple face mask or nasal cannula. So obviously we know that that is very simply nasal cannula, and that will be into the lower range, and that is maybe accommodating slightly higher flow rates there, and your simple oxygen face mask. Okay, and we'll talk a wee bit about the escalation ladder as well. If you're commencing at an oxygen target SATs range of 88 to 92, those are patients that are at risk of retaining carbon dioxide. So we need to protect the amount of oxygen that we give them. And therefore you're going to start with a fixed performance mask, which would be your Venturi masks. So we have 24, 28%. Your 24% is your blue and your white is your 28%, and that is popped on to a simple face mask and your fine bore tubing. Depending on what the patient might prefer, you can use nasal cannula at 1 to 2 litres per minute or one of the fixed Venturi masks. So you will be able to increase the flow rate on these, and they will guide you. The prescription is inscribed on each of the little Venturi devices here. So for example, the white one, 28% at 4 litres. So a minimum of 4 litres per minute has to be given to guarantee that that patient is getting 28%. If you increase the flow rate above 4 litres per minute, you won't go above 28%, but what you will do is increase the flow rate of oxygen and therefore help to decrease their work of breathing. And if you do have people who are experiencing increased work of breathing, their minute volume is up, you're going to want to increase the recommended flow rate there by at least 50% to give them a hand while still protecting them from not over prescribing oxygen. If you have needed to commence oxygen on somebody whose target SATs range is 88 to 92, you're going to obviously need to discuss this with a medic. Seek medical attention, and you will want to do an ABG within 30 to 60 minutes. Always monitor oxygen for the first 5 minutes that it has been applied. Document what their oxygen SATs are and the device and the flow rate that you have given, and monitor that at a minimum of every 4 hours. To maintain target SATs, then you may find that somebody is either going to need to be escalated through the oxygen ladder, or perhaps on the other end is going to be titrated or weaned down. Approximately 1 litre of oxygen is roughly equivalent to the 24% on the Venturi. 2 litres is 28%. Approximately 4 litres is 35%. 5 to 6 litres per minute through nasal cannula is equivalent to 40% on the Venturi, and 7 to 10 litres, which you would be delivering through the high flow oxygen nasal cannula here, and you can see that they're a little bit wider and a wee bit larger at the patient interface there. 7 to 10 litres is going to be equivalent to your Venturi at 60%. Now, if you were finding that you were escalating and somebody was requiring more and more oxygen, you're going to be seeking medical review as per the news chart. When you have maxed out on those interfaces, the next one would be going back to your reservoir bag, remembering that that's 10 to 15 litres per minute delivery there with a full inflated mask. That requires an immediate medical review if anybody is requiring a reservoir bag. Beyond that, and beyond what I'm going to talk about, you have other adjuncts for people in type 1 respiratory failure, and after that it would be AirVo, high flow nasal oxygen, or CPAP, and that would require a senior doctor then to make that decision if escalation of care is required and perhaps a transfer to a different ward. For patients within that 94 to 98%, you're needing to increase the oxygen concentration. You're still going to require a medical assessment, and ABG may or may not required. For those in the 88 to 92%, any increase in oxygen will require an ABG, and that should be taken about 30 to 60 minutes after there has been a change in oxygen therapy to allow the body to adjust and maintain an equilibrium on that new oxygen level. When you're hoping to maintain that target saturations and somebody has stayed at a stable oxygen level for 2 consecutive readings, then you may consider titrating oxygen down, and you would go back down the ladder, either titrating the oxygen flow rate through the nasal cannula, or perhaps coming back down through the Venturi masks setting if somebody is on that 88 to 92%. It is worth talking about the patients that are palliative. They may be on oxygen therapy, however at some point it may have been deemed necessary to not monitor their oxygen saturations anymore, and that is the cohort that we would not be looking at saturations and arterial blood gases. Oxygen therapy can help alleviate the symptoms of breathlessness. And it would be used obviously for symptom control and for patient comfort. And in that case you may consider other adjuncts to manage breathlessness, such as opioids or other medications. So just to discuss very quickly, we've talked a few of the devices for delivering oxygen that you might consider on a ward in an emergency setting. We've talked about our nasal cannula. If somebody is going to be on them for a period of time, you may want to consider adding the little padded parts that go round their ears just to make it a little bit more comfortable. This is the simple face mask that you would have considered using, especially if somebody is a mouth breather or has a blocked nose. You might prefer to deliver their oxygen therapy through the simple face mask and the fine bore tubing. Other types of face mask that you may see are the oxy mask. This is very well tolerated by patients. It's very flexible, very soft, and this is something that patients who are on long-term oxygen therapy at home may be used to. So again, patients ambulating who are becoming more short of breath, breathing through their mouth, might prefer a mask like that when they're mobilising. It's something that you may see on the ward. And when using a simple face mask, we need to ensure there's at least a flow rate of 5 litres per minute to prevent carbon dioxide buildup within the mask. If you are considering humidified oxygen, and this would be the case for anybody who has tenacious secretions or tracheostomy or laryngectomy patients, then they would require humidified oxygen. So this is the setup here where you would expect to see the water. And you have this device which would screw in here, pierced at the front when you've removed the sharps cover in through here, and then you're going to select which concentration of oxygen you want. And this little device will guide you as to the minimum flow rate that you need to turn this up to on the wall to achieve that concentration of oxygen. So for example, starting off at 28, a minimum of 5 litres per minute to deliver. Again, if somebody is working hard, they have an increased work of breathing, they're really requiring big volumes of air, you can increase that flow rate higher than 5 to meet their demands, and you haven't increased the concentration beyond 28%. When that is set up, you're going to need your wide bore tubing then to connect to the interface here at the front and to the patient, and you're going to need to put on your mask. Okay, so where you can go from that, if you're needing to turn oxygen therapy up to, and this can go up to 98%, beyond that, if somebody is still not maintaining their target sats, you can use double flow. So you would have 2 of these units, so you need to make sure that your oxygen flow unit on the wall is bifold and it has 2 separate flow rates, and you would set up 2 of these. And what then from that you can do is get the little green Y connector, have 2 relatively short lengths of your corrugated tubing from the 2 units, and then putting your tubing from the Y connector, and that's going to double that up then to delivering 98% at 30 litres per minute. The last little bit that you may need to consider if somebody was still not maintaining their oxygen target sats is to consider tusks, and these should be 10 to 15 centimetres placed into the face mask. Again, this creates a reservoir of oxygen to really maximise their oxygen sats. All of these obviously need to be discussed with a medic at all points to know that your escalation of care can continue to these parts, and if somebody was still requiring further oxygen at this point, that there's a clear escalation or ceiling of care beyond these adjuncts. Of specific concern at the minute is the knowledge that we are going to be treating patients with COVID-19 within the hospital scenario. This is a patient group that we understand are going to become quite hypoxic quite quickly and are going to require potentially high levels of oxygen. We know that when we can deliver oxygen beyond 6 litres per minute on the wall, it is then considered an aerosol generating procedure. That has implications for staffing and levels of PPE on the ward. So it needs to be discussed that if you are needing to turn oxygen up beyond that part, beyond 6 litres per minute, consideration of a side room may be necessary for that patient if they're not in a cohorted of COVID patients. This must be discussed with a senior doctor with a clear escalation plan, because we know from case studies so far that patients who would be considered for invasive mechanical ventilation should be considered perhaps quicker than other patients that we would have perhaps tried going through the escalation of oxygen therapy. So discussing this with our colleagues in intensive care quickly to allow timely intubation and ventilation if that is indicated. We treat all hypoxemia with an urgent clinical review.